My mic is on. All right. Great. Okay, so hello, everyone. So I'm Jennifer Telford. I'm a gastroenterologist here at St. Paul's, for those of you who I don't know. And I will be giving grand rounds today with my colleague Eric Lamb, who's not here. He's on a plane to Toronto, but this is most of his talk. He was going to be giving it today and then realized he had a conflict. So he and I and Dr. Meng here perform EUS at St. Paul. So our talk's going to be focusing on EUS. Before we begin, I would just like to acknowledge that I live and work on the unceded territory of the Musqueam, Tsleil-Waututh, and Salish peoples. And we'll get going. And feel free just to call it with any questions as well during. So I don't have any disclosures. Can you guys hear me okay? Or do it? Okay, even if I'm here, it's good? Okay, perfect. All right, so we're briefly going to review some of the clinical conditions where you may have seen EUS performed or you may perform EUS, and focus on some new EUS guided interventions that are available here at St. Paul's. So EUS has both diagnostic and therapeutic indications, and initially it was mostly diagnostic indications that we use EUS for, but the therapeutic indications are really evolving. And EUS was initially developed way back in the 1980s. So my teenage sons say way back in the 1980s. To look at pancreatic cancer, because pancreatic cancer was a condition that can sometimes be hard to image. Obviously, as our cross-sectional imaging has improved so dramatically, the radiologists are very good at detection as well. But I would say that EUS is really the modality to biopsy pancreatic mass lesions. So that's probably one of the most common and certainly one of the more urgent indications that we see EUS for. I'm not sure if you're aware, but pancreatic cancer is the third leading cause of death now in Canada, and the incidence is continuing to rise. We can also use it to detect choledochlythiasis. So if we have a patient who we suspect may have a bile duct stone, this is a nice sort of minimally invasive mechanism to look for choledochlythiasis. And it performs maybe a little bit better than MRCP, actually, at looking at the extrahepatic biliary tree. We also see cholelithiasis, although transabdominal ultrasound is excellent for that as well. So subepithelial lesions, little bumps that we see in the rectum or in the stomach, the esophagus, the duodenum when we're doing an endoscopic exam on someone, the mucosa is all intact, but there's something underneath that's causing what we call a subepithelial lesion. Those that we can evaluate very well by EUS. For pancreatic cystic lesions, EUS is great for seeing the pancreas. As I mentioned, we can evaluate those cysts. Sometimes we can, our cyst fluid analysis can be helpful in trying to differentiate these precancerous mucinous cysts from ones that really don't have any malignant potential. And then, of course, I mentioned solid pancreatic lesions, liver biopsies, T staging of cancers within the lumen, and also pancreatic biliary cancers, a little bit with end staging as well, but really good for T staging. And then with the therapeutic indications, really the first one that we had was celiac plexus neurolysis for patients who have sort of that intractable. The intractable pancreatic cancer pain. We can place fiducials in pancreatic masses for patients who are going to be undergoing radiation therapy. Fundal varices, we can do coiling and gluing of fundal varices, and this done as we discussed this morning at our rounds in conjunction with our interventional radiology colleagues. And with particularly with new means of creating anastomoses between the GI tract and things adjacent to the GI tract, we can do pancreatic cyst drainages. We can create an anastomoses with adjacent walled off pancreatic necrosis to do endoscopic necrosectomy through. And the four bolded ones at the bottom, I'm going to discuss in more detail today. We can do bile duct drainage, gallbladder drainage, an edge procedure, which is creating anastomosis between the remaining stomach and a bypass stomach in someone who's undergone bariatric surgery with a Roux-en-Y anastomosis and gastric bypass in order to get down to the papilla and do an ERCP when they need them. And then also gastrojejunectomy. So the lumen-opposing metal stents are self-expandable metal stents. So they're deployed down a catheter and then expand once they're deployed. They're fully covered, and they have phalanges, look like little dumbbells at the end that hold them in place so they don't slide around. The newer iterations of these are delivered on a system that has cautery as well, so that when we're in the stomach and we need to make an anastomosis into walled-off pancreatic necrosis that's right next door, we have cautery at the tip. We burn a hole through and then can deploy the stent across it. So that saves us from having to do several other steps that actually had a bit of a higher risk of bleeding and of leak, where we'd be putting wires into that cavity adjacent to the stomach, putting a balloon there, trying to dilate it out, and then, pushing stents through. And, what has been a common thing in GI is we see an indication for an endoscopic type procedure like this. And then we sort of have to troubleshoot and use devices and techniques that weren't purposed for it, that were for ERCP. But now that we have these lumen opposing metal stents, we have, a device that is being used for its intended purpose. The diameters right now go up to 20 millimeters. So, decent, we can get a gastroscope through that. So EUS guided gallbladder drainage. So when you are doing EUS and you come through the stomach into the duodenal bulb, sorry, we can leave that open if it's not so noisy outside. I was just distracting. We're right adjacent to the bile duct, so very close. And here you can see an EUS scope under fluoroscopy, a needle coming out and puncturing the common bile duct and injecting it with contrast to get a cholangiogram. So the duodenum is very close, very accessible for us. So doing bile duct access was first described way back in the 1990s, cholangiogram, and then the first anastomosis back in 2001. For the reasons I just mentioned, adoption of this for, specific indications was really slow because we didn't have the right devices until we had the lumen opposing metal stents. So this is going to be a video here. I wish I had the pause so I could pause it. So this is an EUS scope sitting in the duodenal bulb. And immediately adjacent that, we're going to see the dilated bile duct, which is black, or hypoechoic or anechoic, I guess, up here, dilated bile duct, and then a pancreatic mass right here. So that sort of dark, rounded structure. This is the portal vein below. So you can see that pancreatic mass is involving the portal vein. So this is a patient who wasn't, who was considered to be unresectable with liver metastases. Here, the needle coming out of the scope. You can see that white line. And then the needle here going back and forth in the mass for tissue acquisition to get a core biopsy. So this can be done, it's one advantage, can be done during the same procedure. In this next part of the video, you're going to see the echoendosonographer poking the bile duct here. So the duodenal lumen is right here. You can see how close it is. And that scatter of white was the cautery and the catheter going in to deploy the first dumbbell. So as the catheter is withdrawn, then the self-expandable metal stent can spring outwards and deploy the first dumbbell. So that'll come out in a minute, right? I can't really fast forward on here for some reason. It was showing earlier. This is the area we're watching here. You can see some movement happening. Sort of readjusting their position there. And you're going to see sort of a bright white thing kind of widen in this area in just a sec here there. So that's the first dumbbell there. Hope you can appreciate that. And it's the rest of it still in the catheter going back into the duodenum here. And now they are deploying the second dumbbell, which we don't see as clearly. You just focus right here and you'll see the second dumbbell and then just the short stent in between. Right, so there's a second dumbbell right there in the duodenal lumen. Oh, I'm in a loop. Great. All right. So how does this compare to what we've been doing for years? So ERCP and stent placement. There's two randomized trials that have been published. So the Durango trial was a multi-center randomized trial at 10 international sites. So Australia, some Asian sites, and some European sites. And they randomized patients with distal malignant biliary obstruction that were unresectable to either undergo EUS guided bile duct drainage using a lumen-opposing metal stent, like you just saw, or to our sort of traditional ERCP with placement of a covered self-expandable metal stent. And their primary outcome was stent patency at 1 year. So the proportion of patients who still had a patent stent at 1 year. They looked at a variety of secondary outcomes, including technical success, clinical success, and adverse outcomes. So as you'll see in this table here, the stent patency between the EUS, guided biliary drainage, and ERCP was not significantly different between the two arms of the trial. However, the technical success of placing it was significantly higher in the EUS guided biliary drainage arm. Sorry, did someone have a question? Just have their mic unmuted. So the technical success was significantly better. The procedure time was also shorter in this EUS arm, 10 compared to 25 minutes. And the adverse event rate, there was no significant difference between the two. So you'll see here the two Kaplan-Meier curves. So the one on your left shows the Kaplan-Meier curve of stent time to stent obstruction, basically, with patients censored if they died or were lost to follow-up, and then drops in lines as the stents obstructed, and there was no difference between these two arms. And then the Kaplan-Meier curve on the right is patient survival. And again, there's no difference between the two arms. The second trial was called the Element trial, and this is a Canadian center, and we were one of the sites enrolling for this, so it's quite exciting to see. 11 Canadian sites, again, randomizing to EUS guided bile duct drainage, or ERCP, and this was unresectable, locally advanced, or borderline resectable distal malignant biliary obstruction. I think you guys can appreciate when you looked at that EUS that our window is really in the common bile duct, sort of between the common hepatic duct. So it really is that distal cancer. If the cancer is sort of up here in the hilum, we don't have that window that we can get to it from the bile duct. The primary outcome was rate of stent dysfunction at 1 year, so the inverse of stent patency, and they also looked at technical success. The rate of stent dysfunction was analyzed to look for a superiority between the two arms, a superior strategy between the two arms. Technical success was analyzed in a non-inferiority assessment, and they had similar secondary outcomes. So the rate of stent dysfunction or stent patency was not significantly different between the two arms. The procedure time again was significantly lower for the EUS guided biliary drainage, and the adverse event rate was not lower. The technical success was 90% in the biliary drainage arm, 83% in the ERCP arm, with a risk difference of 7.3, quite wide confidence intervals that indicated non-inferiority. So neither was inferior to the other, unlike the first trial where technical success was better in the EUS arm. And here's the Kaplan-Meier curve of stent patency for the Element trial, and that you can appreciate here that there's, isn't a difference between the two groups. So EUS guided choledochal duodenectomy seems to be a safe alternative to ERCP in distal malignant biliary obstruction. Some added benefits: you can get tissue acquisition during the same procedure. You can access the bile duct and get a stent in, even if you have duodenal obstruction from the cancer. And with experience, it's actually technically easier. It's very straightforward for us to do it in most circumstances. ERCP can be straightforward as well, but often not in these patients. You can imagine if you have a big pancreatic mass near the ampulla, it could be involving the ampulla. There's a tight stricture downstream that we're trying to get a wire across. So that's why the time difference is there. It takes a lot longer. So there will be more results coming out from the ELEMENT trial, so cost effectiveness analysis and long-term stent patency rates. So using the lumen opposing metal stent, the stent that we use here at St. Paul's is $5,000. So the other biliary metal stents are in the range of sort of $800 to $1,000. So it's quite a big cost increase. In terms of billing, I think the physicians, from a societal perspective, we get paid more for ERCP than we do for EUS. But it will depend ultimately probably on which patients require more procedures, either because they had an ERCP, the brush cytology, as can happen, was negative. So EUS guided fine needle biopsy is more accurate for diagnosing pancreatic cancer, for instance, which is the majority of these patients. So it'll really depend on how many additional procedures I think these patients need long-term, which will determine that cost effectiveness analysis. Great. Any questions before I move away from the bile duct drainage? Okay, this was the best data. Now the data gets a little bit less and less valid after this. So I started out with the one that we have the most information on. So gallbladder drainage. So patients who have acute calculus cholecystitis who are not considered to be great candidates for surgery, they have a few options. Traditionally, they would get a percutaneous tube placed in their gallbladder by interventional radiology and sort of, cool them down on antibiotics before their cholecystectomy, or they may have it long-term in patients who were quite comorbid and elderly, and the surgeons didn't feel would do well with surgery. We have a couple of endoscopic gallbladder drainage options as well. So one is doing ERCP and putting a stent into the bile duct and then trying to swing it over into the cystic duct. So we have a stent actually going into the gallbladder as opposed to going up the bile duct. And that actually can be very effective. It can act as sort of a wick for bile, and it can be left in long-term, some studies have shown. We don't have a ton of experience with it here, but in terms of what the literature shows, although these classic stents can get blocked pretty easily, just having the stent in the cystic duct kind of helps maintain that flow and prevent recurrent cholecystitis. And then using these lumen opposing metal stents or LAMs, the other thing that we can do, because when you have acute cholecystitis, often the gallbladder is quite dilated and it can be right next to the duodenum or right next to the stomach, in which case we can access it through EUS and place one of these LAMs. So here's an image of a percutaneous drain. So you can see the drain coming in on the patient's outside, going into the gallbladder. The radiologist is shooting contrast, you're getting a cholangiogram, dye spilling out into the duodenum as well. So the main advantage of this is right now it's much more accessible to folks. So I mean, here you had St. Paul's, you have access to, well, in VGH, you have access to all these different modalities. But you can imagine in more community centers that this would probably be the easiest access. It can be done up in the ICU under ultrasound in patients who are really sick. So I think there's an accessibility issue. And if this is a patient who could later on go and have a cholecystectomy, this I think I'm not a surgeon, but I think this is sort of the easiest thing for them, maintains all the normal anatomy. So the disadvantages are that the patients don't like them. They hurt, it's uncomfortable at the drain site, and they can be a bit finicky. Like they're constantly, if any of you have looked after patients on the inpatient service, the chance of having this tube last their whole admission is low. Like they get caught on things, they get pulled out, and they block. So ERCP transpapillary gallbladder drainage, requires an ERCP, so it has some disadvantages there because you absorb all the risks of ERCP like pancreatitis. The stents can migrate. The advantages of ERCP are that, often these patients, maybe they have like bile duct stones too. So you need an ERCP anyways to remove them. So you kind of get a 2-for-1 in that case. So here's a duodenoscope coming down to the papilla. And this is a little plastic single pigtail stent. So it's placed up. You can kind of see a bit of contrast there, I think, in the bile duct. But you can see this has actually been directed up the cystic duct into the gallbladder, contrast in the gallbladder, and it's curling there. This also doesn't hamper the surgeons for future cholecystectomy. For EUS gallbladder drainage, as I mentioned, we're using the lumen opposing metal stent. The big advantage of this is you have, as you can imagine, this big stent sitting in the gallbladder, and you can actually go in with a scope into the gallbladder and take out the stones. So they may never need a cholecystectomy, which is probably a good thing because we don't know yet whether if we put a LAMS in the, between the gallbladder and the stomach or the gallbladder and the duodenum, what that does to the future cholecystectomy. Can they still have a laparoscopic cholecystectomy? Would it have to be open? Is the complication rate higher? So we don't know the answer to a lot of those questions. So I think right now it's really reserved for those patients who are considered never cholecystectomy, like they're never going to the operating room. This is really, we're palliating this gallbladder. So there is a randomized trial called the DRAC1 trial. This is actually the same group. I'm sorry, you can't see my citations there as well, but I'm happy to share my presentation out. This was the same group that did the DRAMBO trial. So the same 10 international sites, Australia, Asia, Europe. And so they randomized patients who were at high risk for undergoing cholecystectomy and had acute calculus cholecystitis to either EUS-guided gallbladder drainage with aluminum posing stent or a percutaneous IR-guided cholecystostomy tube. Now, the caveat to when you're interpreting the data from this is in that LAMS arm, they went back in like every month and like poked a scope inside the gallbladder and just took out any stones. So these patients had a lot of additional procedures and were getting sort of cleaned out. But when one of the outcomes is recurrent cholecystitis, that adds a little bit of something to consider. So their primary outcome was an adverse event rate at 1 year, including recurrent acute cholecystitis. And then they looked at a few secondary outcomes as well. So I think that's showing up pretty good. So this is a comparison of the clinical outcomes. So in this column here is the EUS guided gallbladder drainage with the LAMS, and this is a percutaneous gallbladder drainage. And so the 1 year serious adverse event rate was significantly higher in the percutaneous arm. So they're, quoting, nearly 78% here versus 26%. A lot of those are accounted for with recurrent acute cholecystitis. Reinterventions after 30 days would also come up, and that would include reinterventions for acute calculus cholecystitis and unplanned hospital admission. So some of these will overlap with each other. And the 30-day adverse event rate was also significantly higher. Yes, question.
I have a question about the place of the house. Is that the standard, outside of what they did for this trial, that for patients to go back and have repeat scopes and have a vial and stones straightened out through that?
Yeah, I don't think there is really a standard. Honestly, it's such a new procedure. I wouldn't say that there's anything sort of standardized about it. And we don't have a lot of long-term data. So I think that would be a matter of discussing that with the patient preference. I mean, these were, ASA3 elderly patients. So, I think that, I don't know. You'd have to discuss whether they'd want to have these repeat procedures because you're sedating for them. There's complications. There's a complication risk every time you do a procedure versus just intervening if they had recurrent symptoms.
Yeah, I'm also just wondering in terms of like you're saying right now, comparing it to if this would be a similar comparison to how most patients are treated outside of this trial. But it sounds like there's no standards.
Yes, I would say there isn't standards. Yeah. All right. And one of the other things I thought was interesting about the DRAC trial, I think, at least for me, supports what I've seen clinically with this patient, is they did see that following the procedure for the first few days, that patient pain scores were higher in those patients who'd had a percutaneous drain placed. So these are some images from that trial. I don't have a video for you, but this is EUS, the dilated gallbladder here, hyperechoic gallbladder wall, the needle puncturing the gallbladder. You'll recognize this from the video you just saw. So this is that LAMS dumbbell being deployed inside the gallbladder. And this is an endoscopic view from the duodenum. Here's the LAMS. You can see the sulfur-spinal ascent looking into the gallbladder lumen. And here, this is a bit of a dark X-ray, but you can see that there is perhaps see that there's a LAMS there on the X-ray with the two dumbbells. So these are the most recent clinical practice guidelines from the American Gastroenterological Association, looking at patients with acute cholecystitis who are poor surgical candidates. So they, in their algorithm, as you can see here, they felt that if there had been gallbladder perforation or a high suspicion for gallbladder perforation, that these patients were still probably best managed by percutaneous gallbladder drain. So otherwise, they recommended endoscopic, either a transpapillary stent placement or EUS guided gallbladder drainage. And the EUS gallbladder drainage, again, this is based on expert consensus with like a relative paucity of data and trials, that the EUS guided gallbladder drainage may be relatively contraindicated in patients who had a lot of ascites. It's because any fluid in the belly sort of pulls things apart. And you want nice apposition of the gallbladder from either the stomach or the duodenum in order to put the LAMs in. Also, if this was a temporizing measure and these patients were potential candidates for future cholecystectomy, it would be better to do the endoscopic transpapillary stent. Certainly, if they were undergoing ERCP for another reason, why subject them to a second procedure when you might be able to do everything during that procedure? And then EUS is not feasible if the site that you're trying to get your LAMs into is more than a centimeter away from the lumen that you're attempting to make the anastomosis with. On the other hand, reasons why a transpapillary stent might not be possible. So if the patient has gastric outlet obstruction, you can't get down to the papilla. If they have an indwelling metal stent that is in the bile duct that's going across the cystic duct, that can make it really challenging to get in. And if it's a covered stent, one would say impossible. And if there's a large stone burden within the gallbladder, you might swing more towards the EUS guided gallbladder drainage with the thought that this patient's at higher risk of recurrent acute cholecystitis, and you can get rid of the stones in the gallbladder. The last thing I would just say on that, I think that slide highlighted nicely, that this is, a multidisciplinary approach. So, the patient's most responsible provider, your echoendosonographer, interventional radiology, and your surgeon. I think that it's, needs to be approached in that multidisciplinary manner. All right, so gastrointestinal anastomosis. So this is where we're taking two GI structures and putting a lumen-opposing metal stent in between them, pulling them together and creating an anastomosis. So that tract usually matures within 1 to 2 weeks. And the applications that it's currently being used for are for patients who have malignant gastric outlet obstruction as an alternative to a duodenal stent. So creating an EUS guided gastrojejunectomy. And as I mentioned earlier, for those patients who've had gastric bypass surgery and need an ERCP. So with EUS guided gastrojejunectomy, so this is for malignant gastric outlet obstruction, most commonly from pancreatic cancer or from distal gastric cancer. The other alternatives are surgical gastrojejunectomy, duodenal self-expandable metal stent placement, and then the EUS GJ, which I mentioned. So we do duodenal self-expandable metal stent placement. I'd say like it would be nice if they worked better, is what I would say. So they tend to re-obstruct, which, you can deal with. You can put further stents in. But the thing I think is most disappointing with these duodenal stents is even when they're first place and they're nice and patent, just because the stomach, I think because it's been so distended, and there's probably other factors related to the patient's cancer, they're still not emptying nicely down into the duodenum. So we feel due to dysmotility. This doesn't seem to be the same issue as much with surgical gastrojejunectomies, which patients tend to perform quite well after these, although they have to undergo an operation, and there's length of stay, it tends to be longer. But in terms of their patency, I think it's a more durable solution. And so we were hoping with EUS to be able to provide a non-surgical approach to this. All right, so this takes multiple steps. So this patient that we're going to show you here is a patient who has gastric cancer, and they'd had a duodenal stent placed. You can sort of see, I think, the wires right here, and then they've had sort of tumor ingrowths. And so with some gentle pressure, we are able to traverse the area of stricturing. So they do still have some lumen there, but it's, they're clinically, they have gastric outlet obstruction. Again, they're not tolerating oral intake. So trying to gently get through this area and then able to sort of pop through the other side. And that's just normal tissue kind of coming up between the struts. And then you'll be able to see down to the distal duodenum. And so then after that, we put in what's called a nasobiliary drain, although we're not putting it in the bile duct, we're putting it in the jejunum. So we thread it down through the nose, down into the jejunum, and then we fill up the jejunum with water and methylene blue. And now we're doing the EUS, and we found this big loop of jejunum that looks like really nice and filled with fluid right up next to the stomach. And then we're sticking a needle in here into the fluid, and then we aspirate back on our needle to make sure there's methylene blue there. We want to see that blue dye and know that, you know, we're in the spot where we want to be. I don't know that that will always be a necessary step, but I think as we're becoming newly experienced with this, it's you know, we're being very, very cautious with our first few years of doing this. And now this is the Axios catheter that's being placed again into the jejunum. And you saw that little scatter of white there. That was the cautery and it coming through. So like these ultrasound videos, or are they putting you to sleep? And it's not like having like a GI bleeder and blood going everywhere. It's a bit more of a, you're welcome to come watch them live. They're more exciting then, but. So we're waiting for that nice dumbbell to appear as the LAMS is deployed. Dr. Lamb's edited these videos are actually quite a bit longer than what you're seeing here. This is not a 10-minute case, unlike the bile duct drainage. We often will do these patients with anesthesia support with propofol because it is a longer case. You see our dumbbells just deployed there. The catheter still in below it, tugging back, pulling the jejunum nice and tight against the stomach. And then we'll deploy the second bumper. One bumper, two bumper. It's a better view of the bumper in the stomach right there. And then from the stomach, looking down the LAMS towards the jejunum, you have all that fluid that we put in coming back. Usually it slowly expands a bit more over time. This was, I can't remember what he said, whether it was a 20 millimeter, but it'll slowly continue to increase. Some people will actually put a little balloon catheter down and dilate a bit. All right, so we don't have any prospective data looking at, we don't have any good prospective data looking at LAMS for GJ. So there was a retrospective multi-center cohort from expert centers in Europe that looked at US guided gastrojejunostomy with LAMS and compared it to a propensity matched cohort 1-to-1 to duodenal self-expandable metal stent placement. And they looked at clinical success and stent dysfunction, and they had 176 patients that they matched for age, sex, underlying cancer type, cancer stage, and the presence of ascites and peritoneal carcinomatosis. So they found that the stent dysfunction was significantly higher in this non-randomized retrospective cohort than EUS GJ. And the technical success was the same in the two groups. Clinical success was also higher in the EUS GJ, which sort of supports, I think, how we feel clinically looking after these patients, that often after a duodenal stent placement, even with perfect technical success, that the patients just don't do as well as we'd like with their eating. So this is a more technically challenging procedure. And right now, I think just really performed at referral centers that do EUS. And it has been in clinical practice guidelines from the European Society of Gastrointestinal Endoscopy, has been recommended as an alternative to either surgical gastrojejunostomy or duodenal stenting. Yes?
Just before we move on, of those failures, like the 1% EOS cohort, was there like a morbidity associated with that 1%? Like, is there a difficulty in removing the stent itself, or in situ? Kind of what are the considerations after?
Yeah, so I can't remember what that technical failure was. So I just read that last night, but I'm having a hard time actually recalling for that case what it was. I feel like it was a misdeployment. So in terms of retrieving after a misdeployment, it depends. So if you misdeploy and your bumper's in the stomach, but you misdeployed such that the other bumper, the downstream bumper, the distal bumper, is between the stomach and the jejunum, that isn't a problem for retrieving the stent because you can just pull it because you're in the stomach. However, if you deploy your distal bumper, in the jejunum, and then your proximal one, you were to deploy between the stomach and the jejunum, which I've never seen reported happening, that would be problematic because you've now basically perforated the jejunum and created a hole between the jejunum and the peritoneum. So I think that patient would need to go to surgery, and that would be a really bad outcome. Yeah. Yes. No, we will often, right now, we often are doing CT scans afterwards, not specifically for a leak, but just to look at our placement and for some reassurance. But it's a completely covered stent, and they're very very opposed to each other. So normally we would only look for leak if the patient deteriorated clinically with abdominal pain, we suspected peritonitis. Yeah. Great. Any other questions before I move on to Edge? Good questions. All right. So a little anatomy here. So esophagus coming down, and we have a little bit of remnant stomach. It always surprises me when I do an EGD, like how little stomach is there still. A little bit of remnant stomach, and you can see suture lines there. The stomach's being cut. This is the remaining stomach here, and it's been sewn over. And then we have a loop of jejunum that's been brought up. And this is the gastric bypass with the roux on Y anastomosis. So our ampulla is sitting here. So traditionally, how we've had to do ERCP in these patients when they need it is you need to come all the way down here to this anastomosis, find that. So that's like the first half of the battle. And then you need to make that corner, which is really hard, and get all the way up here. So you need a really long scope. So we can't do that even with a colonoscope. We need to use enteroscope, so a double balloon or a single balloon enteroscope to get all the way around. And even then, it's often unsuccessful. And then you get to the papilla, and you don't have an ERCP scope. So you have a forward viewing scope. You don't have a side viewing scope like what we use for ERCP. You don't have your elevator for your devices. So it's probably the most technically challenging thing we can do as endoscopists actually is doing this. So a lot of centers, although I don't think so much in Canada, probably due to access to OR time, it's actually done during laparoscopy with lap assisted. So they'll come in and you can either go in with your ERCP scope, they make an enterostomy, or in some cases you're going down the normal way and you're being, helped along like we do for obscure GI bleeding. And then that's less laparoscopic and more just like lap. So with the Edge procedure, we put a lambs between those two areas of the stomach. And then we can go down through that anastomosis and just do ERCP the regular way. So it's a temporary access because we don't want to create a permanent access because that'll defeat the purpose of this poor person having undergone bariatric surgery in the first place. And so a permanent fistula, so that's considered a complication because the patient can regain lost weight. So now that I've described it, we'll go through a video here. So the first phase is the EUS. So we're down just in that remnant stomach here. And similar to the GJ, we'll usually puncture with the needle into the excluded portion of the stomach and inject a bunch of water in there to really dilate it from when we put our axios in. And so this is the excluded portion of the stomach here. You can see the rugal folds and the needle puncturing in from the remnant stomach. And it's a little bit, I mean, that diagram didn't show, but the excluded stomach's actually quite collapsed. And we like to have a lot of room with the axial stents. So this was confirmed through fluoroscopy. So the needle was put in, contrast injected, and now injecting a lot of water, maybe with some contrast. So that's all that scatter artifact that you see there. Trying to just stand this up and make it big. Here's the catheter coming down for the lambs. Cautery going through. It's actually quite a bit more to go through because the gastric wall, of course, is much thicker than the other, than the small intestinal wall. So you have to go through two sections. Of suturing the space in between. So pushing the catheter in as deep as we can get it, really pushing against that downstream gastric wall as we deploy the stent. And there you can see the lambs coming through there. And there on fluoro. So leaving it in place for 1 week. And now you have your endoscopic view looking down. So here's the Z line right there. You can sort of get an impression of it. Looking down into the excluded stomach. And this is a through the scope CRE dilation balloon. The balloon's being inflated, so we're inside the stent dilating up that anastomosis so that it will easily accommodate the duodenoscope without providing too much resistance. So the balloon's now being deflated. And then pulled back into the scope. And we'll just pop down through the lambs into the excluded segment of the stomach. So then we'll take out the gastroscope and go back down with our side viewing duodenoscope that we use for ERCP. So that's a little trickier getting through here. You see the image is quite different because you're not looking forward, you're sort of looking out to the side now. Another alternative is we can remove the lumen opposing metal stent and just go through the anastomosis. I've had situations where it kind of falls out So there's a stent going through, going towards the duodenum. See, as we get down towards the pylorus here, you can see up at the anastomosis, the scope coming through. Right, and now we're down in the second portion of the duodenum. There's the major duodenal papilla cannulating. There's our cholangiogram right there. Doing a sphincterotomy, so just some cautery along this wire to cut through the sphincter of Oddi and just create a larger opening to retrieve any stones through. Lovely gush of bile, which we always like to see. And little pigment stone. So now coming back through the stent, and now the ERCP is done, the patients have their sphincterotomy and we can remove the stent. You just use some grasping forceps, so forceps that have like little teeth at the end to grab it. And there it is. Right, so again, as I mentioned, as we go through these procedures, the data becomes more and more poor. So we also only have retrospective studies comparing edge to laparoscopic assisted ERCP. This is from Europe. And there was no difference in the success rate of ERCP or adverse events, but a shorter procedure time and length of stay for edge. It could be a day procedure compared to surgery. So take home points. So I think that lumen opposing metal stents, what I really want to express to you is how they've revolutionized what we do in EUS and just having access to create anastomoses. I think for bile duct drainage and malignant distal obstruction, I think it would be fine to consider this as a first-line therapy. It does have some advantages in being able to do tissue acquisition during the same procedure. And I'd say the downside is going to be the cost of that stent is quite a bit more than the cost of the biliary stents we place at ERCP. Gallbladder drainage, I would say only in non-operative candidates and really as a multidisciplinary discussion. Gastrojejunectomy for malignant gastric outlet obstruction, I think we would accept this as a second-line therapy after duodenal stenting failed, and that's what we do, and we're really awaiting a randomized trial for these patients. And then ERCP access for patients with Roux-en-Y altered anatomy. We do need more data in this area, but I would say that there isn't a good alternative in these patients. The ERCP, the surgically assisted ERCP, I don't even know how we would get that here, honestly. And the double balloon ERCPs are just, the technical success rate is low and they are just technically very challenging. Great, so that's all I had, but I'm happy to answer any more questions from you all in the group or folks on Zoom. Which I can't see the Zoom, so you'll have to yell out. Go ahead.
One question. You mentioned the data regarding EOS versus GASTP in the expansion.
Yes. Yes. Yep. Yes.
So can you extrapolate data from that?
It hasn't been compared, so I don't know that I would extrapolate data from it. I think we use percutaneous biliary drainage here. Now, if we fail at ERCP and we can't gain access through ERCP, we prefer to have everything internal. So the percutaneous drains are uncomfortable for the patient. And they get pulled out and they get clogged, and it's similar to the cholecystostomy drains, the percutaneous biliary drains are very similar in that regard. Our interventional radiologists here are absolutely amazing, and they can, they'll place metal stents just as we would. They'll do tissue brushings just as we would during ERCP, but the patient is usually still left with a biliary drain, at least for a period of time, because if they remove it after going percutaneous, then they'll end up with a bile leak, which is really painful for the patient. So in some cases they can ultimately remove it. So we do it in patients that have failed ERCPs, but it hasn't been compared yet. I would say because EUS performed so favorably to ERCP that I don't know that there'll ever be a trial in that regard. Yeah. Great. Good. Any other questions? Great. Thanks all of you for coming. Actually, not a bad in-person crowd. I can't see if there's anyone on Zoom who has questions. I don't have a Zoom screen here, so you can come off mute and yell them out if you have any. I assume I'll be able to hear them. All right. Thank you very much. I know it's very exciting for us too. I know. Was it putting you guys to sleep? No, it was good. Oh, good. So I used to find EUS like really like soothing to watch. Right, feel very sleepy and but yeah. The stents are fantastic.
That's one of the few rounds, right? I had no desire to look at my phone.
Perfect. Good.
Really good.
Oh, good. Thank you. Well, I know a lot of it's Eric did a really nice job with those videos, although they seem a lot longer when you're just standing there with everyone watching.
I'm on calls. No, but I think I can survive your process. Actually, it's like live timing.
Yes, it is. Like when he's filling out the GM.
Yeah.
I know. Actually, well, I think we have some other things that we could add to them as well, like some more endoscopic images to the videos. I think we should just have a little bit of a library amongst us of videos that we can use for talks. And like I have photos of like the methylene blue being pulled out in the screen. So I think that kind of adds to breaks it up a little bit.
Exactly. Yeah.
So good.
I
know.
I don't know. Nick was like,
I know. It needs a visual. Really like it's just complicated. Yeah.
Thanks for the
good. No problem.
Share this image with the.
Oh, yeah. That's nice. You just like a section that you state these things.
I need to start doing that.
Yeah, I do that.
feel like I see them.
Some of the guidelines stuff, like some of the page and stomach, just things that I
yes. When I start studying before that.
Yeah.
I'm from the US, I'm a leader.
Sorry. Thanks for coming, you guys. Okay.
Yes, where is everyone else though? I guess it's copy.
I think I can recommend it. Just like the juniors would learn some stuff that the guys see and also and you'd be okay. It's all right. That was it's so true. There's everything was like a baseline at some point, but that's like there's some specialties for
Don't you see life like you when you're a kid, you thought everyone did what they were doing.
yeah.
Like competition, pretty much kind of making it up.
Yeah. It sounds like a little bit better of an idea based on their experience.
Yeah.
Kind of how to navigate these things. So,
Yeah.
but do we know anything?
No, nobody ever had.
It's very free.
So like, if you don't have the answer, like, is there a chance that things go wrong?
The unfortunate thing is the patients don't.
Yeah, they think that you're like a doctor. Cure their diabetes and everything.
It feels nice to be called too much.
Yeah.
And then you don't have the answers. It's pretty hard. Oh yeah. It's right here. Code master tool. Seconds.